Hey everybody, welcome to the podcast. This is episode 20. As a general review, every podcast that we have, we typically start with a case. It's usually the last case or patient I treated prior to the episode, to the recording of the episode. We then go into questions from the audience and then finish with a general summary and recap. So today we're going to jump right in. Let's get right to the case. So today's case is a 16-year-old female who just had ACL reconstruction. She just tore her ACL not too long ago and just underwent surgery. Now, I have only actually seen her for her preoperative visits in which we looked at different things and got good measurements and baselines and those type of things. But I felt like she was a good case to discuss because we laid out a fairly comprehensive and a bit novel program to instigate almost immediately after surgery. And so I felt like that may be a good thing to discuss here on the podcast. And so she just had surgery a few days ago. Prior to her surgery, she came in for 2 preoperative visits. The first preoperative visit was predominantly just to make sure that she had good range of motion, that her quads could fire, and that overall she would seem like she was in pretty good condition for surgery. She tested great. She was walking in, no assistance, no crutches. Her pain levels were very low, which is exactly what we want to see. When we measured her knee, she actually demonstrated a loss of extension in her knee, which is a problem. So we gave her some exercises and some things to do to try and improve her extension, getting her knee straight. I did quite a bit of hands-on that day to get it straight, and we did so without hardly any pain, which is excellent. Her knee flexion was just fine. We didn't really have to do much there. She did demonstrate a little bit an issue with quad contraction, mainly just because I think she was fearful. But actually, once we kind of worked a few things there in regards to some biofeedback and other things, her quad came back nicely, and we seemed to be able to get everything normalized fairly quickly. And so that was her first visit preoperatively. Her second visit preoperatively was again to make sure all things were in place and ready for her surgery. It was also to discuss the type of surgery she was going to have. At that point, she had gone to 2 different doctors and gotten opinions on what they felt like she should do. She ended up opting to go with a doctor that was more closely associated with the professional soccer team here in town, as well as opted to go with a different type of graft than the other surgeon. The graft that she went to, the graft meaning the piece of tissue that they're going to use to repair her ACL, the graft type was a bone-to-bone patellar autograft. It's essentially part of the front patellar tendon. They take part of that in addition to 2 pieces of bone on each side, and then make that into the new ligament inside the knee, the new ACL. And so she opted to go with that surgery. Since we knew what type of surgery she was going to have at that point, we could better give her advice on how to maybe manage it following the surgery. And so what we did over the next half hour to 45 minutes of that second postoperative visit was we decided, okay, hey, look, here's my thoughts. Here's the things that we need to improve. And there's 3 main things that need to happen immediately postoperatively, which I feel like really play a role in getting these athletes back as quick as possible. And that is we have to control swelling. We have to control their ability to maintain good quad functioning. And then obviously we need to make sure that they have good range of motion as soon as possible. And so we put together protocols to address all 3 of those. I guess there's another one too, and that's that we worry about her quad becoming atrophied, losing muscle mass after the surgery. So we had protocols for that as well. And so that's what I wanted to discuss today in today's case. So in regards to the edema or swelling that we were going to be worried about following surgery, they purchased an electrical stimulation device with the main purpose of just creating non-fatiguing muscle contractions to stimulate blood flow, and more specifically the lymphatic system of the body of the leg, to help decrease the amount of swelling that is present and to obviously get rid of that swelling as much as possible. We know that the body gets rid of swelling and edema through muscle contractions by pushing fluid back into the bloodstream, but it also uses the lymphatic system to get rid of any extra fluids, specifically those fluids with molecules that are too big to fit in the capillaries and into the bloodstream. And the way that lymphatic system works is it's basically a negative pressure system. Imagine trying to milk a cow backwards. You have to squeeze the udder, stick it in the milk, and let it go, and it sucks the milk back in. Well, that's how this lymphatic system, to a very basic degree, works. And so you need muscle contraction surrounding the entirety of the leg to try and improve the lymphatic system. Now, someone who's just had surgery, that may be very difficult because they may be braced, they may have some pain, those type of things. So then we used a device, or had them use, or am I going to have them use a device to create those muscle contractions, but do so involuntarily. They don't have to think about it. And so it just does it on its own. And so we laid out a protocol to help improve with swelling there, where they're essentially using this electrical stimulation device anywhere from 2 to 4 hours, 4 times to 6 times per day. The idea behind this is that it's not going to affect the incision, it's not going to affect anything negatively, and we needed to try and continue to get the fluid out of the leg as much as possible. And so that's one of the things we use to address the edema and swelling, which is one of the problems we normally have. So we are also worried about quad atrophy. We mentioned that. We're worried about maybe them losing some muscle mass. And there's been some studies, specifically one by, I believe it's called Takarada, in 2001. It's a bit of an older study, or 2000 I think it was, where they used blood flow restriction training immediately post-operative with ACL patients. And all they did was they put the band, the blood flow restriction device, on the leg and let it run for 5 minutes. I believe it was 5 minutes on, took it off for 3 minutes, and then did 5 minutes on again, and they did it for 5 times in a row. So it was 5 minutes on, 3 minutes off for 5 times, and then they did that multiple times per day, usually twice per day. And what they found is they had a significant reduction in the amount of atrophy in the surgical leg. And that's pretty good, considering all they did was put it on and increase the pressure, and that was it. And so in her case, in my patient's case, we had her on that exact protocol done twice per day with one additional component, and that is I wanted her working while she's on those 5 minutes, just lightly doing maybe like ankle pumps, just basically moving her ankle around, trying to flex her hamstring and trying to flex her quad while she's under with BFR, but at a very, very minimal contraction and intensity. The point here is, again, the more activation we can get, it doesn't take much of that BFR on to produce a training effect, and so any bit will help, and any extra counts. And so we're trying to mitigate the atrophy using the BFR protocol. That started day 2, technically day 3 after surgery, and so she's currently doing that. Now, one of the things we also worried about is obviously pain. She had a concern that she didn't really want to use narcotics. She was a little concerned that she wasn't going to feel very good on these narcotics, and so we gave her another option in regards to pain mitigation, and that was using the same electrical stimulation device, which had a pain function on it, and to use that for a certain amount of time. In her case, we had it use upwards to 45 minutes to an hour to help decrease this pain that she may have. And so that was one of the ways that we're going to help mitigate pain. And we're also a little bit worried about her quad not firing and not doing very well there. There is a protocol that we may have her start using. We don't have her start using it immediately, mainly because it does require the electrode pads to be placed a little bit closer to the knee. And at this point, I really just want to avoid infection. And so we'd like to keep it covered and keep it away. And so we have a whole protocol that's driven to try and improve quad activation, that it incorporates using electrical stimulation of another electrical stimulation device, and this time also a biofeedback unit, to try and just basically not let her lose anything that she already had prior to surgery. We know that we're probably going to take a hit, and that's okay, but the idea is to decrease the amount of hit we take during this time period right after surgery. And so that's the protocol we laid out. I sent it to her in just a nice spreadsheet type form, had her told her to follow it, and we hopefully will be able to see some improvements and see some good results. We did take some measurements previous in regards to quad size. Obviously, she didn't have surgery, so we didn't necessarily take any edema measurements, so we won't necessarily be able to measure directly how well the electrical stimulation protocol went. However, what we'll definitely know is, if she's moving fairly well and her pain and her edema levels are really low upon her first visit when she sees me, which should be within a week, usually 7 to 8 days following surgery, then we know that it's working, because it's a decent surgery with a lot going on, and we want to make sure that we want to give her the best chance of getting back as fast as possible in regards to getting things going. And so those are the protocols that we use to help her through this very beginning phases after an ACL reconstruction. I can tell you that she's doing very well. I talked to her. There was a little concern about maybe the incision not closing and those type of things, but otherwise she seems to be doing well and has been able to go through these protocols. But we'll see how well it turns out. Hopefully it goes really well. We've done these protocols in the past. I personally have done these protocols in regards with other patients, one with a total knee patient and multiple patients who just underwent Tommy John or UCL repair. We did very, very similar protocols using electrical stimulation devices and those type of things. And so there's subtle nuances that we obviously couldn't and we don't do in the elbow, but the idea is very similar protocols that seem to have worked very, very well and allow us to get a jump on range of motion and mitigate the loss of muscle and get these athletes moving again to make them feel better and better, and then get them going on their protocols so they can get back to their sport and as soon as possible, as soon as safely as possible. So, all right, that's our case for today. I'll try to give you an update in the future on her. We'll probably have a few updates just as we go through some cool things that we're going to be trying with her that are coming down the road that don't happen immediately, but some things that have worked in the past and some new things. So pretty exciting stuff there. So, all right, we're going to jump into questions here. Just as a reminder, if you do have a question for the podcast, you can always go to the website, www.athletic-potential.com/podcast. There's a button there to click to say ask a question or submit a question. Please do so. They'll ask you for some information. You do not need to put an email if you don't want to. However, if you do put an email, it does allow us to answer your question a little bit more directly. So please consider doing that. And if you have questions, please ask them. We'd love to answer them. So, all right, question 1 comes from James. He says, I have a 12-year-old son who plays a lot of different sports. Fantastic. Let me just stop right there real quick. Absolutely, 12 years old, should be playing a lot of different sports. If it's baseball, great. If it's football, it doesn't matter. The idea is just to play what's in season is kind of the general recommendation that we hear a lot of these days, and it's still a really good recommendation. Remember, we're not trying to build the world's best baseball player at 12 years old. You're trying to build a very good, robust athlete, someone who moves well in a variety of sports, learns how different sports work, and then eventually will specialize into a sport later on. So, James, so far, good on you. Keep them going in different sports as long as possible, okay? It continues with the question, what is your recommendation in regards to training? What should be the primary focus at this age? Okay, so I've answered a lot of these training questions, and they're always the same answer. However, you ask a very specific question: is what are your recommendations? So what should be the primary focus for this age group? And I can tell you this right now, that obviously you want to teach them the basic movements. So that's your squat, your hinge, your push, your pull, and your carry. They got to be able to do all of those really well, and they've got to show that they can do that without external resistance, so without weights or anything like that before they can graduate to a weight. Now, that being said, I can tell you right now that the primary focus at that age and younger, and the younger we get them, it seems the better. Now, I say that, I'll be honest, I've only trained one kid under the age of 8. If they're under the age of 8, I basically don't know if it's worth it at that point, unless the kid is far advanced and playing up with these other kids. But realistically, at that point, I just want them to go play and do lots of fun things and just enjoy their time playing different sports and expose them to a lot of things and just let them figure out movement over time. And but 8 years old, that's typically where I kind of start. I like teaching the movements earlier than that, but as a form of play, not as a form of training. And so my 11-year-old now, she started picking up a kettlebell when she was 5 or 6. It was very light, but we kind of just we played around and taught her how to hinge and taught her how to squat because she wanted to. And my 7-year-old now already knows how to do all those movements because she saw me doing them and mom doing them and big sister doing them, and now she just plays around with it and enjoys those just as much. But the idea is it's more of a play thing than a training thing. So James, back to what you're asking in regards to our primary focus with maybe these 12U kids. I can tell you this, a lot of the 12U kids that we see are kind of that, they're starting to develop. They're starting to get a little bit taller. They're starting to get a little bit longer in regards to like limbs and arms and legs, that kind of thing, torsos. And they start to look like that newborn giraffe every once in a while once they start to really sprout and go through these major growth spurts. And so one of the things that we predominantly focus, and I'll be honest, I would argue to say that this is a focus not only at the youth level, but all the way up to our professional level guys. We will test for this, and we will train this in our pro guys and our elite level college guys as well, because we see deficits in this across the board, and we want to make sure that if they don't have this, we need to fix this. And so, and no, I'm not trying to be elusive, but the idea is that what we predominantly focus on here is the ability for these athletes to control their pelvic position. Now, when we say pelvis, think more of like their posturing, but on their between their bottom of the rib cage to their pelvis. We want to make sure that posturing is done well. You'll see a lot of these athletes run into issues. Before we even teach push-ups, I teach them a plank on hands position. It's the start of a push-up. It's the top of a push-up. And most of these athletes, specifically the younger athletes, don't hold that top very well. Their back's arching. They're in this anterior pelvic tilt. The way to imagine it is your pelvis is a bowl, and it's full of water. So if you tilt the bowl forward and it pours water out the front, that's an anterior front side pelvic tilt. If you tilt the bowl backwards and it pours water out the back side, that's a posterior pelvic tilt. And what we see in a lot of these athletes is that they have these poor pelvic tilts. They just can't control it very well. Specifically, it seems like there's more anterior pelvic tilt that we have an issue with. But both exist, and so we put them in these positions. We test them when we see it, and a lot of them just innately struggle with it. And like I said, the pro guys will struggle with this too. When we had a 6'5", 240-pound pitcher that, to be honest, we had to retrain his pelvis to actually stay in position, and it only helped it and improved his ability to throw harder and better. And so in the youth athletes, we'll put them in positions and see how well they can control that pelvic tilt or that pelvic position. And then we will go through a series of exercises to train them, typically laying on their back to begin with. And we have them actually just do pelvic tilts, max posterior pelvic tilts. We tilt the pelvis back. We kind of show them what it is. And we go maximum as much as you can back, dumping the water out the back side, then go maximum front, dumping the water out the front side, and then go back to neutral, and then front, back side. And they do it as a part of the warm-up just to kind of teach them what it feels like. And then what we do is then we slowly integrate harder positions. So we go from laying on their back with their knees bent to laying on their back with the legs straight, which usually pulls them into pelvic tilt a little bit, so they have to learn to control that. From there, we'll typically go to either a quadruped, so hands and knees, teach them back and forth, back and forth, back and forth there. And then we'll either go from quadruped to plank on hands position, which is a little bit harder, and then we'll go from there to a standing position. Sometimes, cause I feel like they in standing, sometimes they get it a little bit faster. I know that the progression usually calls for that you go to what's called tall kneeling, which is both knees, you're kneeling on both knees and staying up nice and tall and trying to control the pelvis. And what we found is I think most of those kids, they can't even kneel like that without substantial compensations. And so actually I go to standing first, teach them what it's supposed to be like there, and then go into this tall kneeling position and have them do those things back and forth, back and forth, back and forth until they understand. And then typically what we will do is we'll start that training process with them there, whether in a tall kneeling position and trying to basically move their arms into different positions, whether reaching our arms up overhead or whether they're trying to reach across their body without turning or just like rotating. I wouldn't even say rotation, it's more like arms rotating or arms reaching across their bodies. Once they can maintain pelvic position with that, then we'll start maybe adding, like give them a 2-pound to 4-pound med ball, pushing it away from them, and even maybe like start using bands or cables to try and do where they push the band out in front of them. It's called a Palloff press, where they push the hands out in front of them, is trying to rotate them, and they maintain that good stacked pelvic position. And I can tell you that we had an 11-year group, 11-year-old group that I trained, and we never got out of tall kneeling. 12 weeks of training, and we stayed in that tall kneeling position, working on pelvic position the entire 12 weeks. Now we were doing all the other movements too, your hinges, your RDLs, your squats, push-ups, those type of things. We're doing all those, so we were still taking the concept of good pelvic position and applying it to those big basic movements. However, we were still spending a decent amount of time teaching pelvic control. And to be honest, if these kids are going to continue to play, they'll have years to figure this out. And as their bodies change, they're going to have to keep learning it. And so I'm totally fine with, that 11-year group's now 12U. I'm going to start training them pretty quickly here. And we'll see how many of those kids will be able to maintain that body position, that pelvic position as their bodies change. And so, James, I hope this answers your question in regards to what do we predominantly focus. I can tell you, I spend a lot of time making sure that they can show me proper posture. And it usually almost always starts with the pelvis. And so if you're wondering what you should do, start there first. If you're going to training and they're doing all sorts of stuff, but their pelvis is not in the correct position, you're teaching compensation patterns that are only going to get worse I think they only get worse as that athlete ages and changes and their body develops and matures. And so it's something, if they learn quickly and do so at a younger age, then they tremendously benefit. As a side note, total anecdotal, meaning it's just my personal experience. My 11-year-old, she's a softball player, but also does gymnastics. And gymnastics they talk to them about posture and pelvic position all the time, and they have to maintain it, because if they don't, they fall over, right? It's all balance. So the pelvis has to be centered, and that's taught her to maintain pelvic position better than anything else, mainly just because it's a lot of reps. It's hours per week working on these balance positions and making sure that they can move correctly and generate force from the pelvis. And I can tell you from a softball perspective, that has only benefited her. And so for whatever that's worth, that's where I would start, is look at pelvic position in the 12-year-olds or any youth athlete. Make sure they can demonstrate good pelvic position, and from there you just kind of maintain it and have them keep working the basic movements, the hinge, the squat, the push, the pull, the carries, and some rotational stuff as well in regards to med ball throws. And I think you're going to be in good shape at that point. So, James, good question. I really appreciate that. Next question is from Zach. He says, what are your thoughts as to why players who have had Tommy John return to throwing with more velocity than previous? This is a absolute, this has been talked about for probably a good decade to 2 decades now. And this is a question I answer constantly, and the good news is I'm getting less of the, hey, does my kid just need Tommy John surgery so he can go out and throw harder, even if he's healthy and has no pain? And I'm happy to say that I don't really get that question anymore. I know it exists, and I know people think that. A lot of people sometimes still think that. But what we found is that that's actually not true. It isn't. It's not a surgery that's guaranteed. So there's research coming out on this all the time, and so I'll quote basically kind of what I've heard and what I've heard surgeons say and what I've read in the research a little bit. And I always tell everybody, look, when we talk about Tommy John surgery is a fantastically successful surgery, but not 100. Still 9 out of 10 clients or athletes who have this surgery, more specifically to baseball, at least return to playing, and a lot of those, 8 out of 10, return to the same level of sport or same level of competition as previous. That is fantastic surgery, really, really good. But that's returning to the same level of competition. Now, if we look at velocity improvements and or do they restore to their normal velocity measures, the answer is yeah, a lot of them did. I'll tell you this, not all of them, and definitely not all of them threw harder after. A lot of them did, but not all of them. And so the surgery itself does help. If you have a damaged UCL or ligament in the elbow that's limiting your ability to pitch, you need to, and you want to continue to play, you need to get it. You need to have the surgery and you need to have it fixed so that you can perform at the highest level. That being said, there's no guarantee that you're going to increase your velocity following surgery. Now, I'm going to go ahead and tell you a couple things in regards to cases, people that I've worked with where we've seen a loss of velocity. So that one's really quick. I'll tell you that in a second. And then I'll tell you a couple stories that are pretty much the same in regards to those that had gained velocity. And I'll tell you why I think they actually gained velocity. And I don't want to say, I'm going to say, I think the surgery helped. I actually had a healthy ligament, but it definitely wasn't just the surgery. And so Let's talk about the guy who didn't get back. So the guy who didn't get back, he had the surgery. The surgery went extremely well. Range of motion, everything came back. Everything looked great. Shoulder range of motion, everything looked good. But the only issue he had was, for some reason, he could not get back to velocity. And he was able to play. He was able to play a couple seasons. And then never really got to the point where he could get maybe advance. And so I argue a lot of times we look at the research and that would say, oh, he didn't return to the same level of sport. And the answer, I think he did. I think he got back to the same level, but he just didn't get better after that. And that wasn't because of the surgery. It wasn't because of his elbow. I don't know what it was from. It may have just been he just hit his peak athletic ability and maybe that was it. And to his credit, he worked hard. He did everything he could. He had the surgery. He did everything we asked him. He trained with us for a while. And realistically, I think what ended up happening is he kind of hit a limit, and then he noticed that, maybe the sport wasn't, he didn't want to play it as much as more and lost the drive for it, and that kind of led him away from the sport, which happens to everybody eventually, right? But the idea is, despite the fact that having his surgery, he basically had to work really, really hard to get back to where he was before and didn't see any additional velocity gains. This is a guy who was throwing mid-80s when he had his surgery. And so he got back to mid-80s. I think he was touching 85, 86, which is what he was normally doing previous. So that's a story of a guy who didn't see a velocity increase. Now, he got back. So I definitely would say he didn't not get back. He got back, which is fantastic. But let's talk about a couple of other guys. So we had a player come in, had Tommy John surgery, and he was normally like a 92 to 94 mile an hour guy. And we had the surgery. He comes in. We started his rehab. We do everything we needed to do, and making a very long story, long process, 12, 15 months process short. He topped out at 99 later that year. So 18 months after the surgery, he hit 99, and then was subsequently drafted. And so a lot of people are like, well, yeah, surgery was great. And I'm like, yeah, surgery was fantastic. It took a ligament that probably was getting a little stretched and probably needed to be, eventually was going to be a problem. It tore. They got the surgery and allowed him to just kind of keep progressing. Now, when I say keep progressing, that didn't mean that his surgery turned his arm into this to be able to throw 99. It allowed it, gave it the capacity to do it. But I think the reason why he came back throwing harder than ever is he actually had time off. He took time off from baseball, had to because he had surgery, and took time off from baseball and worked on the areas that were not very good, where he was inefficient, where he was suboptimal, and he worked on all these other areas that he had that needed work. And what that ended up doing is it improved his kinematic sequence, it improved his strength, it improved his rotational power. All of those things have also been found in the research without surgery to increase velocity anywhere from 1 to 3 miles per hour. And so we're talking to guys 94 before. He got in a good strength conditioning program. There's a couple of different researches look at that, but it's anywhere from 1 to 3 miles an hour increase. So say it's a 2, we'll just say 2. He went from 94 to 96. He really wasn't ever on a fantastic arm care program. Also a 1 to 2 mile an hour bump if you do one of those. So let's say it was a 2. Now he's at 98, right? And now we're talking about what else is he? Well, guess what? He actually had a structured throwing program that progressed over time rather than just going out and willy-nilly throwing whatever he wanted. Now we know that that's correlated. They didn't correlate to how much that improves, but all he needed was 1 mile an hour. Bam, he's throwing 99, topped out at 99. And so we talk about guys having surgery as Tommy John and they come back throwing harder. I think a lot of the reasons why we see that is that's the first time in a very long time that these athletes have had a prolonged period of time, 3 to 5 to 6, sometimes 12 months, without constant competing in baseball. And so it's a forced downtime for these athletes to go out and improve on all the areas that they're not very good at because they have time. Now, most of the time, these athletes need to be evaluated so they know what's not optimal. They need to have good training programs because you can't just train whatever you want when you're trying to come back from the surgery, so they have to have good training programs. And they have to have a progressive throwing program that's catered to them. And so obviously it definitely works if you go somewhere that know how to do that. Now obviously that's what we do here at Athletic Potential. We're not the only facility in the country, in the world obviously, that does that. And I think that's the reason why we see a lot of these athletes throw harder, throw better, become better pitchers or better players after the surgeries because they have now spent a significant amount of time improving their overall game more than they had ever before. And so It's not the only reason we see it. The surgery definitely helps. But the more I talk to players and the more we talk these things over, I usually almost always come back to the fact I tell the players, look, you're better because of two reasons. One, you have a normal functioning ligament in your elbow. And the second reason is we just spent the last 6 to 8 months working on all the things that were not very good in you as an athlete. And now they're much, much better. I would expect you to be quite a bit better. And so I think that's one of the main reasons, Zach, that we see these improvements. And so, yeah, I mean, it's a great opportunity. I've referred to this in the podcast before, and there's a book out there written by Stuart McGill, and I believe Brian Carroll is a power lifter. It's called The Gift of Injury. Nobody wants to get injured. Nobody wants to go through the Tommy John. It's not necessarily the most enjoyable process. It really isn't. However, it does happen, and sometimes it's what it is. But it's what you do with the time when you're doing the rehab that can be really a gift. You can take this opportunity where you're down and out, but you now have time. And if you use that time very effectively, very wisely, and are mentored through that process, there's a really good chance that you're going to come back as a better player in a lot of different ways. And so, Zach, it was a great question. I appreciate it. All right, well, that's all the questions we have for today, 2 questions. And so as a brief overview, summary, we talked about ACL reconstruction and immediately post-operatively, and we laid out some protocols to mitigate atrophy of the leg, to decrease the amount of edema and swelling that will be present there, and to improve quad functioning as well as to help mitigate pain. We kind of laid out some protocols there. I think the key here is that you have a plan, and you follow the plan after the surgery rather than just kind of laying around. I'm starting to see a theme. We talked about with Zach, hey, you've got an opportunity here. You had the surgery, you got to take care of it, but hey, while you're doing that, let's take care of a whole bunch of other things. And it's the same kind of concept we're looking at with the ACL reconstruction with our patient who tore her ACL. There's a lot of things that we're going to be working on in addition to her leg to try and improve her ability. Matter of fact, one of the things we're going to work on is a lot of pelvic control. And that brings us to James's question, obviously, when he talks about what's the emphasis in youth. Well, pelvic control, the ability to maintain proper pelvic positioning. And in our soccer athlete who just tore her ACL, we are 100% going to be working a ton, and actually already are working on pelvic control with her. And so all these things come together. So a mentor of mine, Dan John, I know I mentioned him in the past, he talks about the body being one piece, and it's something that I truly believe improving one aspect of your athletic ability in one area is only going to complement the other. And so, yeah, I would say make sure you have a plan for whatever it is you're going through, even if you're just trying to get better and you're healthy and you want to get stronger, make sure you have a plan. Understand pelvic control is key and is needed to maintain good athleticism. And yeah. Well, that'll do it for this episode. I really appreciate everybody listening. And if you do have questions, please ask your questions, and we'll keep going on these podcasts. We're at 20. Always fun to hit kind of these more round numbers. 25 is kind of a fun number to hit, thinking a quarter of the way to 100. So anyways, we appreciate everybody listening. And if you have questions, please ask, and we'll catch you next time. Thanks.